aneurysm in the abdominal aorta, and a sudden rupture can kill the patient. So these are the various manifestations of atherosclerotic cardiovascular disease.
To sum up, the patients can present you with coronary artery, which we call normally, that is the only way we know about the angina, but then she can present with stroke, gangrene or the aortic disease also. So risk factors for...
Yes, madam. And aging and female is little protected because of estrogen in the premenopausal state, but after menopause, because of vision failure, estrogen protection is gone, and the lady is equal risk as compared to men, or rather at more risk of coronary artery disease. There are certain modifiable risk factors which are in our hands, like smoking. One should not start smoking. If one is smoking, one should quit smoking. Smoker is considered as a risk factor if he has taken one cigarette in last 1 month even. Then diabetes and hypertension, they are also considered very strong risk factors. Lifestyle modification, lifestyle risk factors like obesity, inactivity and atherogenic diet. These are the main risk factors for atherosclerosis.
So we have modifiable and non-modifiable risk factors, and the estrogen deficiency predisposes them, because whatever clock is there, that clock will be disturbed if we don't give them estrogen. But if we give them estrogen in the window of opportunity, then that clock is not going to be disturbed.
And another interesting point is that this disturbance in the lipid metabolism doesn't occur only after menopause. It's before 3 years of the onset of menopause the changes have started appearing.
So perimenopausal age group is very, very important. So if you have to be for the primary prevention and the patient is having symptoms of heart failure, please continue earlier, start earlier and continue late with the proper counseling of the patient. That is very important. Now we come to the pharmacotherapy, because we are running short of time, so we have to just cut down.
Regarding pharmacotherapy is mainly with the statins. Just previous slide. Pharmacotherapy is with the statins. Statins are the gold standard treatment for prevention of cardiovascular disease, both for primary prevention as well as secondary prevention. What we mean by primary prevention is person who has not clinically diagnosed as a case of atherosclerotic cardiovascular disease, we consider it as for primary prevention. A person who has suffered from a heart attack, person who has suffered from stroke, these are considered as the strategies as a secondary prevention. If a person has got already established, a person has already clinical established disease, statin has to be given. If person has got on routine examination, investigation has found to be LDL level more than 190, has to be 17 cardiac risk calculator. And in this it is a very simple, you open your net through your mobile even, and it will come as a cardiac risk calculator. It is simple, you put your age, your gender, you just questionnaire are there, do you have heart disease, did your father or brother have heart disease, mother or sister have heart disease before the age of 60, next. And just you fill the form and you will get the answer. If your risk is 10 years risk is more than 10%, you have to take statin. Otherwise, every A and B person should not take statin unless he is qualified to take these drugs.
So Dr. Sikka has given very, very important messages that if you have suffered from coronary heart disease, or if you are at risk, diabetic and other risk factors are there, then you should start the statin. But routine patients just in the menopausal should not start statin or aspirin.
One additional point I want to make, that ladies who during pregnancy had preeclampsia or gestational diabetes, they are at greater risk for these diseases. And women suffer from collagen diseases more compared to men, like rheumatoid arthritis, SLE. These ladies are very much high prone to get cardiovascular diseases. One should be very careful for primary prevention in this group of patients. Polycystic ovarian disease is another group. These ladies should have very careful regarding prevention.
So very important points he has highlighted is PCOD patients, preeclampsia patients or autoimmune disease patients. They are very much prone to DVT and they should be taken care of. And when prescribing HRT, please be careful about these patients. Now we come to a very, very important problem, that is of osteoporosis. See in 3 lakh fractures and 2 lakh wrist fractures, and then the spine fractures, which are most common, 2 lakh. These are made more than the incidence of heart disease or the stroke or anything. But still we are not talking about osteoporosis, and we are not bothered about this quality of life at all. So this osteoporosis we are going to talk about is the primary one, or the age-related or bigger menopausal osteoporosis. Secondly, can be because of the senile osteoporosis, which will decrease the ability of the kidneys to produce vitamin D, and then can be secondary osteoporosis because of some other problems which are causing absorption or the metabolism of the calcium or vitamin D is disturbed. So remorting of the bone is going on throughout, and this banking of bone health starts from adolescence itself, maybe from in utero mother's calcium and vitamin D should be replenished. So now today we are just going to talk about pharmacological management of osteoporosis. And Dr. O'Brien will tell us why do we give the newer drugs. First thing, can menopause harming therapy given for the prevention of osteoporosis? Secondly, why do we need newer drugs and what are the new drugs?
To begin with, I will tell you a small story. 18 years old girl with a very high velocity accident. Everybody thought that she has broken all her bones. She went to the clinic and she had only bruises. There was not a single fracture. They x-rayed her and they found that her cortical bones were excellent. Radicular bones were very good. They said, how could this happen? So they x-rayed her mother. Again, she had beautiful, wonderful bones. 150 members of the same family were x-rayed. And they found that if this family had a fall from 20 feet, even the elderly ladies among those family, they are not going to break their bones. Now there are so many factors that lead to loss of bone. We need to understand that. Race, Negroes have better than whites and whites have better than us Asians. Now taking all this into consideration, we come to this condition which occurs unfortunately very early in our country, and what best can be done. Bone is undergoing remodeling. We have osteoclastic activity and we have osteoplastic activity. In 3 to 6 months, the bone turnovers. There is a turnover in which all the bone is changed in our body. Now, whatever drug therapies we have today, they interfere with one of the processes there. Now, what is happening with anti-resorptives? Anti-resorptives are acting on osteoclasts and they are not allowing absorption of calcium from the bone. They are hindering the function of osteoclast. At the same time, they are not really promoting osteoblasts. So what is the situation? The bone is accumulating, the calcium is accumulating, but that natural process of turnover is not there. So what we have is a stale bone. And that is what has led us to believe why not have newer drugs and what are the problems with older drugs. Now most of us are comfortable with bisphosphonates. We say that with our treatment, we can reduce spine fractures by 40 to 50%. We can reduce hip fractures by 30 to 40%. That's very good. But at the same time, there are certain things which are not explained. A middle-aged woman, she's on bisphosphonates for the last 3 years, 4 years, 5 years. She has a spontaneous fracture in her femur. And the cause, there's no trauma, there's very low velocity trauma. Now bisphosphonates are known to cause this. Now why has this bone broken without any trauma? And secondly, when this patient comes to an orthopedic surgeon, the misery starts there for the patient and also for the orthopedic surgeon. This bone will not unite. It looks like a very simple fracture in which periosteum is not torn. When periosteum is not damaged much, orthopedic surgeon is very happy. Periosteum is intact and periosteum is the layer which has osteoclast and this is going to form bone. But in this lady, nothing is happening. And one surgery, nailing, after that plating, after that bone grafting, again the bone is not united. So something is really bad there. So that is why we do need newer drugs, right? So broadly speaking,
5 to 7 years we can treat alendronate, but after that it's not.
We can, and I am not suggesting that we should discontinue. It is a very good treatment, and this complication is very rare.
But after that, yeah, we need special. This complication is there. Our patient has already had treatment for the 5 to 7 years of alendronate.
Okay. So now we come to the newer drugs. If alendronate is not tolerated by the patient, or if we have tried it is not giving us good results, then we have other drugs available, and these newer drugs are again anti-resorptives and anabolic. Anabolic are the drugs which will form new bone, and anti-resorptives again. One important new drug, anti-resorptive, is denosumab. Denosumab is Rankel inhibitor. It acts on mesenchymal stem cells, and it will not allow formation of osteoclast. Osteoclast banega hi nahi to act kahan se karega? So this is what denosumab is doing. It is not allowing the formation of, and this drug, 50 milligrams every 6 months, can be given for 1.5 to 2 years, and the results are very good. The rate of fracture goes down to 60, goes down by 60% in spine and 50% in hips, and it can be given. It can be given in cases with carcinoma of breast, in cases with carcinoma of uterus, in cases with bone metastasis. And I tell you that in bone metastasis, this drug will prevent pathological fracture.
Okay, let's come to other drugs.
Other drugs.
Teriparatide.
Teriparatide. Okay, you want me to speak on teriparatide? Teriparatide is an anabolic drug. It is a derivative of parathormone, and this drug actually promotes osteoblasts. It helps in forming new bone. Very good. But then, as we know, that hyperparathyroidism causes osteoporosis. How come then this drug is acting to make more bone? Parathormone excessive and given repeatedly will cause bone resorption and will cause osteoporosis. But teriparatide given in very small doses once in a while, and this dose is 20 microgram given once a day, and the half-life of this drug is just 1 hour. So it is acting on the body for about 1 hour, right? And it is stimulating osteoclast to form new ones. Now this drug we cannot give if alkaline phosphatase is raised, and we don't know the reason why it is raised. If serum calcium is raised, if the patient has carcinoma breast, carcinoma uterus, you cannot give this medicine, right? And this medicine is known to cause osteosarcoma in mice, and that is why we don't recommend this in younger age group. Of course, that is not.
This is not the first line of drug, then this has to be used as a second line.
As a second line, other drugs are not
Then
active.
what about others? Calcitonin?
Calcitonin is a good drug, again anti-resorptives, and the dose is 200 international units by nasal spray, milligram by nasal spray. And this drug, one good reason is it relieves back pain. So that is why I love this drug. In ladies with osteoporosis back, we keep on nagging about the back pain, and this is one beautiful drug which will give them relief from back pain.
So it's a good drug when the patient is having multiple fractures and she's having continuous back pain and all that. So for pain relief, this is very good. Then what about raloxifene serum, SERMs?
So, SERMs are good because SERMs are selective estrogen receptor modulators. Selective because they act on bone, but they don't act on breast and uterus. So that is one good thing. Though they can have complications like deep vein thrombosis, but the action is good. Result is not excellent. Result is not excellent.
Come to hormone replacement therapy.
Hormone replacement therapy, Dr. Saab has already discussed, and I think it is a good option when there is, in addition to osteopenia, you have other problems that you guys are dealing with.
Yes,
Very
that's it. Yeah, when we have
Right.
other problems also associated,
And
then
I
we
must-
can go for the osteopenia,
must-
not for the treatment of the osteoporosis.
I must also talk about one new drug, romosozumab. It is anti-sclerostin antibody. Now, what is this sclerostin? Sclerostin secreted by osteocyte. It hinders formation of new bone. But once a patient is given anti-sclerostin antibody, this hindrance goes and new bones form at a rapid pace. In some patients, this happens on their own. They develop this antibody and they have lot of new bone formation all over their body. So this is where this result came from. And last
we
of
have
all,
available in our Indian market.
right now we don't have.
No, we don't have, but still we should keep in mind
And-
because whatever is today is not available will become available tomorrow.
And
That is very
the
important.
last thing I want to touch upon is stem cell.
Yes, system is
Draw 40 ml of bone marrow. Simple procedure. You just need to have a needle, push it inside iliac crest, and just draw out the blood. It is thick blood. That is the marrow, isn't it? And this marrow is centrifuged. Remember that. And if that agent acts on the stem cells, this will promote new bone formation. Wonderful, isn't it?
Yeah.
This is a biological way of treating.
Which I think is the way ahead.
But this is again experimental. It is not therapeutic yet.
So now we have to follow these patients. How do we follow the treatment when we are started? When do we repeat the Nexus stent? One thing. Secondly, what about the markers of bone formation and bone disruption?
So DEXA scan is the golden standard for diagnosing osteoporosis. And we know that T-score less than minus 2.5 is osteoporosis, between 1 and 2.5 is osteopenia. Now, this we need to do in all patients, all ladies above 65 years as per Western standards. But as you said that we are 7 or 10 years behind.
We advise the Nexus stent.
So we have to start earlier. And those at risk, who have associated factors like those who are smokers, on alcohol, and other associated problems, we need to do at a much earlier age.
Bone markers?
Bone markers are biochemical bone markers, and where do these markers come from? Whenever bone forms, collagen is in the matrix increases. And when collagen in the matrix increases, it releases certain products which are known as propeptides of collagen. And these propeptides can be calculated. At the same time, when bone formation is getting dissolved, similar markers are liberated in the blood. And important formation markers are bone alkaline phosphatase, myocalcin, and C-terminal propeptide of collagen, and N-terminal propeptide of collagen. These are formation markers, and desorption markers are acid phosphatase, C-terminal telopeptides now, degradation, telopeptides and N-terminal telopeptides. These telopeptides can be calculated in the blood, they can also be calculated in the urine. And what is the importance of these markers? When we put the patient on our treatment, we need to know whether the patient is responding to our treatment or not. That is probably the only indication for these biochemical markers. And if you start your patient on, say, any anti-resorptive bisphosphonate, and after 2 or 3 months you see that your markers are going down, then you know that your medicine is active. That is one good thing. But otherwise, if you want to calculate bone mass, or if you want to calculate the risk of the fractures, you cannot.
For that, it's just the follow-up the treatment. So Dr. O'Brien, you have summed up very nicely about the various new drugs which are available, and we as gynecologists should learn about this and start using them. Because who is treating? They are just treating the fractures. Most of them are not treating the osteoporosis. Patient comes to us as the first touch point. So we should learn about the osteoporosis, and the osteoporosis algorithm is now you start with the HRT. When the patient has come to you with risk factors and other symptoms, then you can put her on SERMs and postmenopausal, or you can put her on bisphosphonates, and the next drugs will be parathyroid, denosumab, sclerostin inhibitors, and calcitonin and all those drugs. We are not talking about the surgical management at all. So this is a big public health problem. Prevention is available. We should do prevention. Calcium, vitamin D is important, because without fuel you cannot have the fire. Fall prevention is very important. That will be taken up in details by Dr. Navneet in another panel. So we are stopping here. Now we come to the role of endocrinologist in our area. So now your important role comes up in the care of the midlife women. Now let's see.
As far as recommendations are concerned, thyroid function tests are not to be done as a screening protocol in the population. The reason is that the prevalence is hardly 0.3 to 0.5%. This is where the prevalence is low and you are not getting that number of patients with the testing screening test. You do not subject the whole population. Like I want subject 200 patients to get one thyroid patient with overt disease. Subclinical thyroid disease definitely is to the tune of around 5%. So as far as guidelines goes from most of the societies, whether American Thyroid Association or the European Union, the guidelines say that routine screening of TSS is not recommended. You can do it when you suspect. When you suspect, when there is weight gain or when there is edema, when dryness of skin is there, you have menstrual irregularities, or there is family history of thyroid disease, or autoimmune disease disorders are there, like patient with type 1 diabetes. There you should definitely do a T3, T4 and a TSH. Second thing about diabetes screening, all women, we with age more than 45 years of age should undergo testing for diabetes. They can do 3 tests, either of these. Either a fasting blood glucose, they can do a GTT, or they can do an A1C. The advantage is A1C is the patient is randomly entering your clinic. You do not need the patient to be in a fasting state. So you can do an HbA1C. If the patient is fasting, you have 2 options. You can do a fasting blood glucose, or you can do a oral glucose challenge test. As far as fasting sugar is concerned, level of more than 126, that definitely is diabetes. Less than 100 is normal. After 2 hours of GTT, the level is more than 200, then it is diabetes. And if it is between 140 to 200 after 2 hours of glucose, then it is pre-diabetes. And A1C more than 6.5 is diagnostic of diabetes. So you can do any of the 3 tests, okay, as it suits you in your clinic, and the patient is coming fasting state or a non-fasting state. The variability with A1C is least, because due to stress sometimes fasting sugars may be high. So HbA1C, it has the least variability. That is, your chance of getting an error is less, but it has its fallacies like anemia is there, or